Hello and good day to everyone joining us from all across the world. And on behalf of the Academy, I am Praveen Chopra, and it is indeed my privilege to welcome you to this episode of Conversations with the Academy. Now today, the focus is on the rapid advancements in the arena of immunology to harness the immense potential in our therapeutic armamentarium against an increasing array of conditions across oncology, virology, rheumatology, gastroenterology, dermatology, and the list goes on with including even ophthalmology, among other autoimmune disorders. Now, understanding this complex human immune system is challenging enough, and traditionally requiring specialized knowledge and expertise with prolonged evaluations. But recent introduction of technologies, including artificial intelligence, genetic intelligence algorithms, smart immunological methodologies, have all enabled even better awareness and assessments of cell types, the dynamics of the immune system, their relative importance, and more importantly, their impact on immunity, particularly in chronic debilitating diseases. Now, we must also keep in mind the commercial ramifications are equally monumental. The blockbuster drug adalimumab, Humira, first approved more than 2 decades ago, has amassed more than 200 billion in global sales. But despite going off patent in 2016 with the patent thicket, biosimilars were still kept in abeyance till 9 Humira reference biosimilars, gives you the importance, by leading biopharmaceuticals were launched in 2023. Now, to explore perspectives in this emerging scenario, we are indeed fortunate to have preeminent faculty sharing their insights and expertise with us today. But before we launch into the discussion, some notes in the session. Now, the audience could challenge the faculty with questions in the Q&A box that you see down below in real time. And just raise your hand or put in the set question and the faculty will appreciate answering them. And the session is also being recorded, which will be made available for on-demand viewing on the Academy website. So now allow me the pleasure of introducing our faculty. Professor Francesco Indiveri, Franco, as we know him better, emeritus professor at the University of Genoa in Italy, who has trained in medicine from the same university and has steered a career path in immunology with distinguished academic roles, including professorship at the medical pathology at the universities of Sassari and Genoa, as well as clinical immunology and in internal medicine at Palermo. Professor Indiveri's extensive international experience stems across prestigious institutions, including Scripps Clinical Research Foundation at La Jolla, Columbia University in New York, and the New York Medical College in Valhalla. He has held leadership positions at the University of Genoa itself, where he has directed schools in allergology and in clinical immunology, diseases of the respiratory system, and you can see his expanded portfolio, including postdoc courses in clinical and experimental immunology with biomedical sciences and technologies. He's well published with over 300 papers, and he remains engaged within advancing the field of immunology as a referee for medical journals, like the Journal of Immunology, Human Immunology, and Internal Emergency Medicine. So you can see how privileged we are to have Franco with us. At the same time, we have Dr. Domenico Criscuolo, President and CEO at Genovax in Italy. With a background in medicine from the Sapienza University of Rome and dual PhDs in hematology and clinical oncology, Dr. Criscuolo, or Domenico as we know him better, has been also immersed himself in the field of immunology. From the early years at Lupiti, where as a clinical research physician, he was leading phase 1 to phase 3 in cardiovascular agents and antibiotics across Europe, to the head of international clinical research in drug safety at Roche in Italy. He has overseen diverse therapeutic areas and also headed up the clinical department at development department at Novus Pharma. He remains involved with innovative oncology compounds and he's transitioned out to the CRO industry as VP at Icon, but then co-founded a startup along with Franco at Genovax. And he's furthering his commitment to advancing pharmaceutical medicine. Domenico has served both as the president of the Italian Association of Pharmaceutical Medicine and as president of IFAP, the International Association of Pharmaceutical Physicians. Well, thank you both for sharing your journeys with us today.
And I will start a brief introduction that was already presented by Praveen So I will move to the next one, and I will make a very short introduction that Franco will complete. That is my vision of the immune system. First of all, I want to thank both Franco and his colleague Gilberto Filazzi that not only introduced me to the immune system, but helped me in the preparation of this slide. Now, to make it very simple, I think that the immune system that is really governing our activities and preventing us from the attacks of the external environment can be considered like a scale. And the scale, when is in perfect equilibrium, everything is doing well, and we are fit, we are able to cope with diseases, with the pollution of the environment, with every external system that can influence our well-being. Unfortunately, scales can move up and down. And what we have, if we have an increase of the effector cells that Franco Indiveri will explain better, we generate inflammation, which is the primary cause of autoimmune diseases. And lupus is the best example of an autoimmune disease. These are long-lasting diseases, devastating diseases because they attack different organs, and unfortunately, the ultimate end is the death of the human organism. On the other side, if regulator cells increase, we have a tolerance. Regulators are, if you wish, a kind of quality control system. In every moment of our life, we have billions of cells replicating. And you can imagine that in this replication, some mistake can happen. Some part of a DNA disappears, or there is a mismatch in the reorganization of the DNA. This is the primary cause of cancer. So when the regulators are losing a little bit of their attention to the replication, to the activity of our body, we have a increasing tolerance, which is the first step towards cancer. So indeed, this is a very simple vision, but you know, according to Descartes, who said that the complex system must be analyzed into small pieces, I think that this, in my view, in my experience, is the best message we can deliver. Immune system is a simple system made of very complex appendices, but the simplest system is based on a scale that can modify the balance, the original balance. Lupus has been the test of many studies. You see, starting in the year 2000, there was the idea that regulatory cells played an important role in the genesis of lupus, and also the group of Franco Indiveri and Gilberto Filazzi worked a lot in this area in order to better understand how to re-establish the balance. Because one issue I think is important to understand, we usually, until a few years ago, were used to treat patients with immune disorders with immunosuppression. which is basically a mistake because we are suppressing even further a system that has already lost its balance. So the target of today, both in cancer and in uh, immunological diseases, is to reestablish the balance, not to kill the immune system with immunosuppression, but to reestablish a original balance. And lupus, as you can imagine, both because of the availability of patients, lupus is not an orphan disease. There are a lot of patients, especially young women, that are affected by lupus. So it's a really social and clinically very important condition. So lupus has been a test for many studies, try to better modulate the immune system, and also at Genovac. Genovac was founded in order to move on into the clinical stage some original ideas by Franco Indiveri and Gilberto Filacci. And so they worked on the idea that a peptide called consensus peptide, given at various intervals to mice, could ameliorate their disease. In lupus, we are very lucky because we have a animal model that can be used in order to speed up the development of potential candidates. As I told you at the beginning, lupus is a long-lasting disease. Usually people start have a diagnosis of lupus at the age of 30, 35, but they can survive 40, 50 years. So doing clinical studies in lupus is very long lasting, but we are lucky because we have a special strand of mice that develop a disease very similar to a human disease, with the great advantage that usually mice live about 30, 35 weeks. So we can compare that 1 week of a mouse, it's about 2 years of a human being. And this helps a lot in the preclinical evaluation of potential candidates. And this, I want just to show you the result of this study that we have undertaken. On the left, you see the kidney, that is one of the target organ of lupus, where if you are familiar with microscope films, you see the round image are the glomeruli that are completely destroyed. On the left side, you see, especially on the right side of the slide, some glomeruli that are completely physiological, well preserved. So in the end, we, I think, made a significant advancement in proposing a new therapy. Now, one question can be in the mind of everybody, especially when we talk today about CAR T cells, gene therapy, the manipulation of lymphocytes, and so on. Because we feel it is a very complex procedure that only very sophisticated center can accomplish. This is not true. As usual, the more we work on a system, the more we are able to simplify it. And you see in this slide prepared by Gilberto, you see that it's made only by 5 or 6 steps. You start from the top left with a blood sample taken from the patient, and then you have a lymphocyte separation, very simple procedure in any lab. Then, of course, you have to send the sample to the GMP cell lab, which, of course, must be certified and working into condition of absolute sterility. But what is important is that the system is closed. You have not to manipulate the cell. You have simple to add your peptide in this case, and there is a spontaneous transfection. Peptide enters into the DNA of this lymphocyte, and after a 24 hours incubation, you have the sample ready for being sent again to the patient and reinfused to the patient. So I want to emphasize this point. The system, for people that are not familiar with this manipulation, may appear very complicated. In reality, as you can see, it's very simple. Any blood transfusion service can run this transfection because the system is closed, there is no external contamination, and you have the sample with the transfected lymphocyte ready to be reinfected to the patient, who will have no adverse event because the lymphocyte you are infusing are the lymphocyte of the patient. So that is the whole story. So I will stop here now, and I hope that Franco can show his slide now. Franco, it's your time now. You are mute, Franco. You are mute. Okay.
Okay. Do I open my slides or is
Yes, go ahead and open your slides.
You can open your slides.
Okay.
And while Franco is looking for it, can you get the audience should realize that I think this is already stimulating some questions in the minds, and please make sure that you are able to raise your hand or add your Q&A and or even in the chat box, and I'm sure that we'll address them to both sides.
Can you see my slides?
No, unfortunately not. Franco, why don't we ask the organizer to present the slides?
Yeah, I asked them to show the slides.
Keith, can you show the slide so we can move on? Okay.
Okay, thank you very much. Okay, the immune system is quite complex, and this activity is based in several steps. So at the beginning, we have a physical barrier. This is the skin and the mucosal epithelium. The skin is a wall, and is an active wall that hosts the dendritic cells, which control the surface and identify the invaders in order to block them and to eliminate them. The mucosal epithelium is more complex because this activity is based on the production of a dimeric IgA and antibodies, which is exposed on the surface of the mucosal epithelium and constitute a biological antiseptic paint. Then the immune system is, the organic immune system is distributed in the organism in lymph nodes, appendix, bone marrow, tonsils, thymus, spleen, and Peyer's patch. Go on, please. Next slide. Okay, the cells of the immune system are divided in two sections, the innate immune system and the adaptive immune system. The innate immune system is actually a border guard. So are cells which are circulating and are distributed in tissues and include neutrophil, dendritic cells, monocytes, granulocytes, eosinophil, NK cells, and the macrophage. These cells are activated as soon as the invader enter the organism and produce cytokines which communicate the invasion to the active immunity, which is activated. And this active immunity include several kinds of lymphocytes, are naive T cells, regulator T cells, memory CD8, cytotoxic cells, helper T cells, cells which activated B lymphocytes, and the plasma cells which produce antibodies. So we have this regular army with effector cells, which are the BCD8 and the TCD8 and B cells, memory cells, and this internal policy, which are the regulatory cells Domenico was speaking before. Next slide, please. Next. Okay, I work this system. This system, the innate immunity is activated soon when a pathogen enters the organism, and the antigen-presenting cells, monocytes, mostly dendritic cells, recognize this pathogen through a receptor, which they express. This is the pump receptor, and the receptor of the dendritic cells, which recognize the pump, they internalize the pathogen and digest the pathogen, getting the ACE protein in peptides. At the same time, the dendritic cells produce a group of cytokines, IL-1, IL-6, IL-8, IL-12, TNF-A, alpha, which activated the T compartment, the adaptive immunity compartment, and the T cells duplicate and become CD8 cells or B cells producing antibodies, where we have the cell-mediated immunity and the humoral immunity. Now I will explain a little bit how this process of maturation to effector cells is activated. Next slide, please. Next. Okay, in this slide is shown the maturation and the activity of B lymphocytes. The B lymphocytes came from the bone marrow. They go to the peripheral organs, mostly in the spleen, where they mature from naive cells to mature B cells. In this process, they express immunoglobulin on the surface, and the immunoglobulin expressed on the surface works like a receptor for the antigen or for the peptides. Then when they go to the lymph nodes, so they are ready to recognize antigen. It can be activated to mature in plasma cells either by recognizing directly the antigen, the peptide antigens, or by the interaction with helper T cells, which present to the B cells the antigen, and this became plasma cells. In both the case, the plasma cells produce the immunoglobulin, which are divided in 5 classes: the IgG, IgE, IgD, IgM, and IgA. The IgA is the one which is secreted in the mucosal in the mucosas, and they constitute the antibody on the surface of the mucosas. Next slide, please. Next. Okay. The maturation of T cells is more complex. The maturation of B cells is performed in the thymus. The thymus is an organ that until 50 years ago was neglected. Nobody knows what he was doing. now we know that is the central of the maturation of the T cells and has a very important function in the immune activation. From the bone marrow of the cells became in the thymus, in the cortex of the thymus, where they measure from the immature cells to measure the T cells, and passing the medulla of the thymus, where is a kind of cells more important, which are the epithelial cells of the thymus, medullary epithelial cells. And these cells are equipped with genes named ARI, which can synthesize all the peptide of a given organism. These peptides are exposed on the surface of the epithelial cells of the thymus, and the T lymphocytes which came in contact with these cells are exposed to recognize the antigenic peptide. In this mechanism, when the T cells recognize in a strong way the peptide, are killed and by apoptosis. The T cells which have mild affinity with the peptide become regulator cells, and the T cells which do not recognize the autologous peptide migrate to the periphery and act as an adaptive immune system. In this way, we have, when the T cells, the T cells which do not recognize the autologous peptides go to the periphery, they are tolerant with the self. But if this system works too strongly, the precursor of cells able to recognize the tumoral antigen are eliminated. So the subject which has this situation is exposed to produce tumors. This has been shown also in my laboratory for the melanoma. Indeed, patients with the melanoma lack precursor T cells able to recognize some melanoma antigens. When the system works less than the normal, we have that cells recognizing the autologous peptides go to the periphery, and this can induce autoimmune disease or can enhance tumor immunity. So the activity of thymus is very crucial either for the autoimmune disease or for the tumor pathogenesis. Next slide, please. Okay, the T cells which came from the thymus go to the peripheral organs, lymph nodes, spleen, and mucosal surface, and they are exposed to different kind of cytokines. Depends of the situation of the organs where they migrate. And here, when they are exposed to interferon gamma or interleukin 12, they become Th1 cells, which function in the tumor immunology and kills cells affected by viruses. When they are exposed to IL-4, IL-10, they become Th2 helper cells, and they are the orchestrate the immunity against parasites or the orchestrate the allergic disease. The cells which are exposed to interleukin 1, interleukin 6, interleukin 23 became Th17, and they are to control the inflammatory process. The cells which became TFH are exposed to IL-6, IL-21, and control the inflammatory activity. So the key of this differentiation is the kind of cytokines which control the maturation of T cells. And we have Th1, Th2, Th17, TFH T cells. This depends on the situation of a given patient or given person in a given situation. Next slide, please. Next, okay. Now we have the activity of the CD8 cytotoxic cells. The CD8 cytotoxic cells recognize the cells which are affected by virus, and they kill these cells. The killing came out from the production of kind of enzymes which are called perforin, which reach the surface of the cells, make an hole on the surface of the cells, and the cells die for apoptosis with an apoptotic mechanism. And the sequence of this activity is the recognize the cells, the release of cytokines, the release of perforin, and the killing of the cells. And here you see the microscope picture of a T cells linked to a tumor cells in order to kill the tumor cells. Next slide, please. Okay, so I showed you how work the system of the helper T cells, how work the system of cytotoxic cells. So here in this part of the slide, you can see the T cells killing, talking with the antigen-presenting cells, and T cells killing cancer cells. In this process of recognizing the antigen and killing the affected cells, we have a production of cytokines which are promote inflammation. So the inflammation could be dangerous for the organism in which it happened. So it is necessary some control of this system. And the control of this system is made by the regulator cells Domenico was calling before. These regulator cells act either by surface receptor, which are switch on cells that activated genes to produce cytokines with anti-inflammatory activity. In this part of the slides, you see the red arrow indicate the cytokines which have anti-inflammatory activity. The activity of the regulatory T cells is very important to maintain the equilibrium between immune activity and danger by the immune activity in a given organism. So we have the Th1, Th2 cells and the regulatory cells which balance each other and do not allow the danger by hyperinflammation, like we saw in the COVID pandemic now. Next slide, please. Next. Okay, so I told you that the cells interact with each other, but which are the mechanisms that utilize for this interaction? The most important mechanisms are two kinds of receptor: the HLA antigens and the T cell receptor. The HLA antigens are protein which are exposed on the surface of the cells, and we have two classes of HLA class 1 and HLA class 2. The HLA class 1 is devoted to present peptides from endogenous antigens. The class 2 is devoid to present peptides from foreign antigens. The HLA is generated from a cluster of genes, which is the most important cluster of genes in an organism, which is on the short arm of the chromosome 6. The constitution, the molecular constitution of HA is that this protein has a groove on its surface where the peptide is linked, and in this way is presented on the surface of the cells, either the class 1 and the class 2. So the HLA is a kind of writer that present antigens to the T cells. To recognize this antigen, the T cells have a T cell receptor, which is a protein exposed on the T cell linked to the cytoplasm. And when the HLA present a peptide, this system is activated, and the cells which recognize the peptide is activated and make cytokines and all the activities related with the cell-to-cell contact. Next slides. Okay, this system works in the organism related with the other system. So we have the nervous system, which produces neuropeptides and control the secretion of hormones. We have the endocrine system, which produce hormones, and the neuropeptides and the hormones, let's say the cortisol, for example, interact with the immune system, activating or inhibiting the immune system. On the contrary, the cytokines produced by the immune system interact with the endocrine system and interact with the nervous system. The most important example of this interaction is the IL-2 and IL-6, which control the temperature of the body. So we have that the modification of the nervous system could interact with the immune system and could create a hyperactivation or down activation of the immune system and so on. Because this is a more important system of balance of our body. Next slide. Okay, now I think that Domenico can start or continue his presentation. Then I will talk after him.
Yes, thanks,
Okay.
Franco. In fact, you answered a very good question already, which was Giorgio was asking around the interaction between the nervous system. That's well balanced. So let's go back to Domenico. Domenico, you also had responded to a question, but maybe if you want to take your session, but there was a nice question from Kim, and we should address that also separately to the larger audience. So, what?
Okay. Yes, thank you. I will now continue, and I will move to the second part of my presentation very quickly. That is maybe an obvious question, but if vaccines are useful in chronic disease, are we trying to develop a vaccine for all chronic diseases, not only cancer? Now, it may be possible in principle because we have understood in recent years this important principle of the balance between the two arms of a scale. Also in the literature, there are some reports of vaccination against arterial hypertension. Arterial hypertension is a chronic disease affecting a large number of patients, millions, maybe billions of patients. So the company that will eventually develop a vaccine against hypertension will be a very successful one. But unfortunately, nothing was moved beyond phase 1. Asthma, allergy to various antigens. So in reality, the system governing the genesis of arterial hypertension, allergy, asthma are much more complex, at least in today's understanding of our studies. Oncology is a different story because in oncology we have done a lot of research, a lot of work. We have identified several targets. We know today that oncology is an umbrella of maybe 200 different type of cancer. But we have invested a lot in this understanding of the various mutation in the various drivers of different type of cancer. And in fact, we have produced some immunotherapeutic agents that are already on the market. So I want to show very briefly some of our experience just to corroborate the principle that once you identify a target, it's possible to identify a vaccine. So telomerase, you may have
Domenico,
heard
are you
about
sharing your screen? Because we still have Kit's screen on this, unless you're seeing yours.
Can you repeat, excuse me?
Kit, are you sharing yours? Because Domenico's slides need to come up.
We were just all right.
Domenico,
See.
you're not sharing your screen because we are still seeing the other ones.
You don't see this?
Hold on. Domenico, does your screen say telomerase? Telomerase?
Yes.
Yes.
Yeah, we are
Yes.
looking at your
Telomerase.
screen right now.
Good. Thank you.
Okay,
Thank you,
this
Praveen.
is
Good. Thank you.
Okay. Well, apologize. Some difficulties always happen. Okay, I am discussing about an antigen that is known since 25 years, telomerase, that is the target of many attempts to produce a vaccine against cancer. Telomerase is a well-known antigen, and so many efforts were produced to move on this. You see, the first publication are dated back in 99 and in 2000. Also, the group of Indiveri and looked at this antigen and were able to confirm the importance of this antigen for a potential development of a cancer vaccine, which in fact it was developed. The vaccine produced by Genovax was a vaccine based on 4 different peptides, all targeting to various areas of telomerase. And this is the result of a phase 1 study showing that in fact the reddish part of the skin indicate the activation of an immune response that it's apparent with a clear inflammation of the skin. And in fact, also in terms of preliminary result, you see on the left side, we have good result, especially in patients who had a strong immune reaction. We cannot imagine that all patients react at the same level. So we have patients with a weak immune reaction, patients with a strong immune reaction, and we could confirm that a strong immune reaction was very beneficial for not only the progression-free survival, but also for the survival of this patient. The second question we asked ourselves is, which is the right dose to administer? Because like all human systems, if you overload them, you produce energy. So in the end, what we have learned is that for activating the immune system You don't need grams, you don't need tons of any agent, but you need just a little bit, just a little switch to light the fire, as the famous song. Light the fire, and then the immune system activated will do the job. That is the secret that we learned after several long attempts. In immunology, you don't need to give the maximum tolerated doses, because sometimes these agents are very well tolerated. So if you give the maximum tolerated dose, you are producing a mistake, not a benefit for the patient. You have to identify the minimum effective dose, not the maximum tolerated dose. The minimal effective dose that lights the fire of the immune system. And that was demonstrated in several publications shown in this slide. And in fact, we did a very large European study run in Italy and Spain with a lot of investigators, a phase 2 study testing different doses of our vaccination. And in fact, we were able to identify that regimen 2, that was more or less the middle between a low dose and a high dose level, produced significantly more responses as compared to the regimen 3 that was the maximum tolerated. So additional confirmation that in immunology, you need to be very cautious. You don't need to exaggerate with the dose, because usually these compounds are very well tolerated, but you are not looking for the maximum tolerated dose. You are looking for the minimal dose that will activate the system. And in a sense, you see, I mean, this is obviously not acceptable from a scientific point of view, but just for the sake of a discussion, we make comparison between our results and the result of a well-known drug in prostate cancer, which appear quite similar. So, in conclusion, and before giving the word now to Professor Indiveri for his final remarks, several projects are ongoing for new and more efficacious cancer vaccine. But I think it's important that after, I would say, 30, 40 years, maybe the first real immunotherapy, which I had the opportunity to develop, was interferon alpha. Interferon alpha started the clinical development in the early 80s, and I work with interferon alpha a lot with Franco Indiveri, and working with Franco Indiveri, we learned that interferon alpha had to be given at very low doses, because that was the trick that we learned in immunotherapy. So after about 40 years, we can say that immunotherapy is now considered the fourth weapon against cancer. We have surgery, we have radiotherapy, we have chemotherapy, and finally, we have also today immunotherapy. Thank you, and I would like to ask Franco to conclude this conversation.
Thank you, Domenico. I think you brought a good point, and I'm conscious of the time. So, Franco, we just got a few minutes. If you could just wrap up the whole conversation and your own, and how do you see this? How do you see new technology affecting these advances or our benefit? Keep in mind, we just got a few minutes to wrap up, and then we will close the session. So, go ahead, Franco.
Okay. May you show my slides?
Keith, can
Yeah,
you
just give me one moment.
Okay.
We've had a lot of people in the audience who have been working with this. So thanks for the interest that has been shown. So go ahead.
Okay, the technology, I would say that the three tools are very important for development of the immunology. The first one is are the monoclonal antibodies. The monoclonal antibodies were introduced at the end of the last century, and the monoclonal antibodies are antibody produced by hybridoma cells, which include the B cells, which are sensitized with an antigen, and myeloma cells. So we have an hybridoma. We have the memory of the B cells and the capacity to grow in vitro from the myeloma cells. They are cloned, and each clone produce antibody which are identical and recognize specifically the antigen. This was the first tool for the study immunology. The second tool, next slide. Next slide. Okay, is an instrument. This is the flow cytometry. No, back, please. the one before. Okay, the flow cytometry. Okay, is an instrument which utilize monoclonal antibody labored with different color. The cells go through the flow cytometry, and a laser identify the different color and allow to select the cells. So we can, in a few minutes, can recognize antigen expressed on the cell surface and classify the cells according to the antigen which are exposed on the surface. This has been a very important progress, because before we were using an optic microscope, so we could see one cells, and with the immunofluorescence, we can recognize one antigen on the cells. Now we can recognize up to 10 antigens on the same cells and classify these cells according to the protein they express. And using this instrument, next slide. Next. We classified the cells of the hematological system, differentiating more of them. And the third tool we have is the molecular biology. With molecular biology today, we can analyze the genome, and we can predict what is going to happen in an organism. We can analyze the transcription and the RNA, and we can define what is happening actually in that moment. We can identify the products of this activation with the proteomics, and we can identify the byproduct of this activation, so we can study all the steps of the immune activation. Mixing these three tools, monoclonal antibodies, cytofluorimetry, and molecular biology, we can have an important and more deep inside of the activation of the immune system. This is the end of my presentation. I would just comment one thing about what Domenico was saying. He showed our data about the vaccine against tumor. This is very important. But if we think of the presence of the regulator cells and at the presence of the adaptivity of tumor cells, which are able to produce inhibitor cytokines, we have to combine the vaccination with the anti-checkpoint activity in order to block the regulatory cells and allow the more activity of our vaccination. This is the idea we are thinking about today. Thank you.
Thank you, Franco. I think this has been a wonderful opportunity for the audience to listen to not only the innovation that has been brought up, but the advances that still have an opportunity to show the potential that this new instrument, a new tool could give, especially with the focus on vaccines today and the ability for us to bring innovation faster to the market. Of course, the conversation can continue forever. There's so much interest in this, and the audience, and the fact that the audience has stuck on and still continue to listen shows the resilience and the interest in this topic. So this is not the last word, so to speak, and keep in mind that this conversation opens up several chapters for us to be able to continue the dialogue. So trying to bring this to the close, it only remains for me to thank the panelists for sharing their insights, also the operations team for providing the platform, and of course, and the engaged audience, which have brought their voice into this conversation, which really offers hope that innovation will continue to make a difference in the patient communities around us. So on that wonderful note, and the note to be able to be optimistic for the future, have a wonderful rest of the day.
Thank you, Praveen. Thank you, Franco. Thank you, Keith. And thank you for your attention. Bye-bye.
Goodbye. Thank you. Goodbye.